Hello, hello, hello. Hello, good evening. How are you? How are you today? My name is Tunde Disu. And once again on today's program, I'm here with my daddy. Dr. Daniel Imoideme is once again on the program tonight. Sir, I want to welcome you once again for setting this time out to be with us, to enlighten us, to teach us, to show us a more perfect way. For those of you that are just joining us for the first time, Dr. Daniel Imoideme is my daddy, first of all. He's also a consultant, gynecologist and pediatrician. He's a fellow of the Royal College of Obstetricians and Gynecologists here in the UK and the same in Nigeria, and also a fellow of the
Nigerian College of Obstetrics and
Nigerian College of Obstetricians and Gynecologists. Dr. Imoideme has over 40 years of practicing experience. He is a pioneer in the reproductive medicine, both here in the UK and especially in the Middle East, and even in Nigeria as well. I forgot to say that last week. Even in Nigeria. We have a great honor to have him on this program. I can't stop saying that because you and I know what it would take to have such a person on a program like this, especially to have him with us every week. This is the 4th week that he's been with us, and it's an honor, sir. We appreciate you. We do not take this time for granted, and judging by the feedbacks and even the comments during the programs, it goes to show how valuable these sessions have been to all of us. Now, I want us to bear something in mind. To whom much is given, much is expected. What we have had on this program since Dr. Imoideme has been with us is enough to answer a lot of questions. However, we believe that understanding is the key to learning. Therefore, from all that has been said over the past 4 weeks, there are specific areas where individuals have questions. During the week, I put out a video saying, Dr. Imoideme is going to be with us. Please send your questions to the email address that I gave. We've had 2 or 3 questions so far, which we'll be looking at during this program. However, you still have the opportunity to send your questions. I will put the email address again online as we go along. But tonight, what we are looking at tonight is the post-investigation and pre-treatment procedures. Post-investigation and pre-treatment procedure. As you can see, we're going through the whole spectrum here. On behalf of all of you and of myself, I want to once again say, Dad, thank you. We honor you, sir. And on that note, I will turn the table over to Dr. Imoideme. Thank you, Dad.
Good evening, everybody. It's nice to be with you again. Last week, at the end of our discussion, I did say that what we'll be doing this day would be to answer questions. Is the way that I look at practice. It's a two-way affair. It's not a one or unidirectional sort of communication, because the more I know your difficulties, where you do not understand certain things, the more I'm able to appreciate where you're coming from and be able to provide answers. I did say at that time, last week, that we were deliberately going to make this a purely questions and answer situation, and that you should send in your questions prior to this day. However, we haven't got that many questions, so I have tried to fill in the gap by looking at what happens between when you do your basic investigations, which identify what is the reason for infertility. Once that is a major part of it, what is the reason for infertility? You do the investigation to identify those areas. And then once that has been identified, what then goes on? What is the discussion that follows before you then go on to say, this is the treatment that is most suitable for your situation, and this is what you are able to accept as an individual, because the doctor cannot impose a treatment on you. It's you, the individual, who knows your needs, who know how far you are willing to go, because the options will be so variable and so wide, and that's something we'll be dealing with in the coming week. Now, what I've done basically is to spend the first 30 minutes of this session looking at or recapping on what we have done previously. We looked at the investigation, and the last slide I showed last week showed what we do on the male side and what we do on the female side, a summary of everything that we do in terms of investigation. We talked about the history, and then we talked about weight. We talked about, for the man, semen analysis and culture, bacterial culture, to see if there's an infection. We talked about chlamydial infection, which needs to be screened for. We talked about hormone investigations, depending on the semen analysis result. We also talked about testicular biopsy, if it becomes relevant to do one. These are the stages for the investigations that we would normally be looking at overall in a broad outline in a male. In the female, again, we will look at history, because history is very important. We also will look at the weight of the female. We will look at her cycle, the regularity of her cycle, whether she ovulates or not, and the pattern of that cycle. We will also look at hormone tests relevant to what the cycles have been. We also will look at other hormones that can affect fertility, things like the thyroid hormone and other reproductive hormones that may become relevant. We'll also look at the infections of the past that may well still be present, that needs to be treated. We will also look at the womb and the fallopian tube, what I call the uterine and tubal integrity test. This constitutes the summary of what we did last week, looking at all of these parameters. Now, when we then decided to look at, having done all of this, how do we apportion causes of infertility? We looked at, and I did explain that the largest part of the infertility situation comes from those in whom we investigate and find no cause at all, in about 30%. Those who have problems with ovulation constitute about 27%. Those who have tubal problems like tubal blockage or damage, or womb problems like fibroids, scar tissues in the cavity of the womb, or polyps in the womb cavity, constitute about 14%. Male factor about 20%, and the rest of it about 39%, a combination of both male and female factor. So these are the various categories of potential broad outline of causes of infertility. Once we've identified this, and what will usually be our aim for wanting to do all of this, take the history, do the investigations, then identify where and what category of infertility this is. It is to help the doctor and the patient to make decisions about the most appropriate treatment for that specific condition. Because if you don't get that right, then you are unlikely to be offering the most optimum treatment for that particular situation. And the reason why you want an optimum kind of practice is because you want the best practice advice. You want to be able to give the best advice to the patient. You want to be able to say, what I am doing here today is what another doctor will be doing in America, will be doing in Australia, will be doing in New Zealand, will be doing in China, because you want a streamlined management that is standardized and is of uniform standard around the world, not cut corners and treatment that really do not offer the patient much of any benefit at the end of the day. We also want to look at costs, because infertility treatment is an expensive journey to make, simply because it is not guaranteed at any particular treatment time. Say, for example, a lady comes in, or a couple comes in and they have a treatment. The doctor cannot guarantee you a pregnancy, cannot guarantee you that you're going to have a baby, cannot even guarantee you that as you walk through this clinic, you will eventually walk out with a baby at the end of the day. So these are some of the problems that, perhaps we would, are likely to face. So we need to be able to identify accurately and thoroughly all the various possible problems that can occur before we start the journey. So then, what are the sort of pre-treatment actions that we need to be looking at? The first one that can be very obvious is as a patient walks into your clinic, you can see, does this patient look overweight? It doesn't matter whether it's male or female. Weight can affect fertility in both male and female. So it's an action that we need to look at and take the relevant action on. On the female side, I did say to you that what we call the body mass index, which I gave you the formula last week. The formula I said was the weight in kilograms divided by the height in meters squared. Okay? That formula should give you a value of anything between 19 and 29. That is what we call the BMI, Body Mass Index. It is that range of 19 to 29 that is the optimum for reproduction for a female. A female who is under 19, say 18 and below, is underweight, and the body may not be too ready to carry a pregnancy. Miscarriages will be more often than would have been expected. If the BMI is above 29, then they are overweight. And when that goes over 35, then they are obese. And you begin to have other problems, menstrual problems and irregularities, difficulties getting pregnant, again becomes an issue. So weight is something that we must try and institute a management formula for. It could be through going to a nutritionist. It could be through your general practitioner who will be able to help you manage your weight. But I always say to people, a lot of patients one sees will tell you, oh, I don't eat a lot, I only eat very little. But that is not the fact. Because if you were to take a pencil and jot down what you take every day, if you are overweight, and you think you are taking very little in, you'll find that you're actually consuming much more than you are supposed to have been consuming per day. Somewhere in the region of 1,500 to 2,000, no more than 2,000 calories per day. But generally, prefer around 1,500 calories per day. So, it is a question of what do I eat? How can I manage myself? The most important food item that we now know is sugar. Any sugary product, that you eat is likely to give you weight. We, in the past, used to concentrate so much on the fat. Oh, don't eat so much fat. We'd never really get to eat so much fat. But we eat a lot of sugary stuff in our daily lives. So sugar is the target. Cut down on sugar. And perhaps the best thing I would say, I'm not a nutritionist, is see a nutritionist who may be able to guide you through that. Exercise is another thing that can help as well. And of course, there are medical treatment, medical tablets and so on that people use, for weight loss. But again, I always advise, if you are embarking on a weight loss program, do something that you know you can do in the long run. Not something you do for 2, 3, 4 months, and then 6 months later you are putting back on the weight that you've lost. No, it doesn't help in any way.
Maybe the weight
Okay?
wasn't lost.
So, weight is very important. Most women would notice that, which is one thing, particularly when I was working in the Middle East. You'll ask a lady who comes in, what was your weight before you got married? They tell you, I was very slim and all that stuff and so on. Then, what then happened? I'm not sure whether it's marriage that does it, or it's the satisfaction and the knowledge now, the peace of mind now that I'm married, let them, take off and, and decide that, well, weight issue is no longer an issue. It's not just for the husband, it's for the health and particularly reproductive life in the early phases of the marriage and of life as well.
Just 1 minute.
Yeah.
Well, as you can see, this train is on the move. I don't want to have so many breaks by me having to stop that from flowing, because as you can see, he's in his element. However, 2 things. Number 1, let's go and share this program. Let us help somebody and help ourselves. That has just been talking about weight management. That relates to all of us, whether married or single, whether you have children or no children, is irrelevant. Weight management is something that we all can do, I can do within myself. So it is not just sharing to help somebody. It is also sharing so that you can have a footage of this on your timeline. Maybe after this program, maybe next week, maybe in 2 weeks time, you want to, what was doctor saying about weight that day? You already have that footage on your program, on your timeline, that you can refer back to and listen to it. Secondly, by you sharing this on your timeline and sharing it with the groups that you belong to, you are actually helping somebody who perhaps will not have the opportunity to hear this type of message. So please, let's help ourselves. The second thing is, I have posted the email address for your questions. If you have any question, instead of writing it on the on the program, which will scroll away, why not just send it as an email to the email address that I gave? The email address is theadmirals@yahoo.com. I will post it again, but if you have any question, please send it as an email so that we can catalog it and Dad can attend to it later. Thank you, sir.
So we carry on, and the next thing that we, during our investigations, we looked at on the female side is the cycle length and regularity. Very important, because it tells us a lot of story as to whether or not that female is ovulating. Are the cycles regular? Are they short? Are they long? They tell us a lot of stories about the length of different phases of the cycle and how those can impact on fertility. So we can, by learning about the length of cycle, then go on to say, look, before we go on to do a treatment, if, for example, this lady comes in and she has a period every 3 to 6 months, once every 3 to 6 months, you know that she needs cycle regulation. She needs to have a pattern upon which you are going to base your treatment. Otherwise, you just are not, you just are at a loss as to where to start your treatment when you decide to start treatment. So cycle regularity will be very crucial. If, for example, the lady had periods once in a year, some women have periods once in a year, you know, not because they are not fertile, they have eggs in their ovary, but because of some hormonal disturbance, they have very irregular periods or very few periods. Therefore, you need to regulate these cycles by giving them some hormone, you know, correction, you know, to make them have, it may not be cycles that are fertile. They are not fertile cycles, but they are cycles which you want to base your treatment on, because the way cycles go is such that I did show you a diagram last week which shows that the cycle is divided into 2 phases. One in which the egg is growing, and then after ovulation, the second phase in which the lining of the womb is prepared for the implantation of the embryo that is coming. So, if a woman has too short a period, it may well be that either of those phases is wrong and needs to be corrected and adjusted for before any treatment can commence. Or if the cycles are too long, either any of those phases is either too long, and then you have to say to yourself, which of these phases is it that is long? How can I correct it? So that's an action that needs to be taken before treatment actually starts. The next phase will be the medical history, which we got while we were looking at the history on the first visit. We are looking at, did any of them say they have diabetes, thyroid problem, or did we find that they have anemia or something like sickle cell anemia or any other medical illness? You want to be able to correct those. For example, diabetes. You know that the chances of miscarriage following a woman who has not had a proper control of her diabetes is much higher than one who has had a control. Or somebody who has a thyroid problem would also have miscarriages, recurrent miscarriages, or may not even get pregnant at all. Anemia is a condition that does not allow you to get pregnant and carry the pregnancy successfully in most cases. And if the woman does carry the pregnancy on, it will be a very tedious exercise. So these are issues that can be identified during the investigation. Diabetes, we need to correct that. We need to refer you to a specialist who is a diabetes specialist, a thyroid specialist, or a hematologist who is a blood specialist. You need to be able to identify all of these things, correct them before we then move on to treatment. Now, social habits are also part of what we talked about last week when we said we look at the history. Do you smoke? How many cigarettes a day? Do you consume a lot of alcohol? Do you use recreational drugs? You know, do you wear tight clothing? Do you do night shifts? Do you do long distance driving and all that? As a male, in which case you can have the testicle subjected to high temperature over long periods of time. These are events that you need to tackle. If a lady smokes, then she has to stop smoking. We cannot reverse the damage that's already been done by the period, during the period she's been smoking. But at least we can put a stop to that. The same goes for the man. In the case of the man, perhaps, yes, we can improve the fertilizing ability of the sperm, because that is what is damaged. They will normally be able to produce sperms normally, but the fertilizing ability of the sperm is what smoking damages. And so the sperms may be there in large numbers, movement may be normal, they may look normal in shape, but their ability to fertilize an egg will be impaired. You know, by stopping the habit of smoking, they can improve their fertilizing ability dramatically. Alcohol abuse can also cause reduced testosterone level in some men and lead to loss of libido, poor erection, and perhaps low sperm count in some situations. Recreational drugs, again, I come back to that. I talked about Indian hemp, some time ago, and I hope that none of us who's listening here needs to be on the high on such drugs. I don't call them medications. So that in itself we know can damage sperms and can cause long-term problem to sperm production. So these are events, these are actions that we can take well before we start the treatment, because we know the treatment is not going to be 100% satisfactory or guaranteed to give us a pregnancy. But if we can take out as much of the negatives before we start the treatment, then our chances are much better. This is the diagram I was just talking about. That one, it's not very important. Now, I also talked about the infections. Looking at the infection, during our investigation, we talked about chlamydia, which we know can be very common. It's a very common situation we find in women who have tubal damage. We know that up to 30% of women who have had chlamydia more than once have their tubes damaged. And let us look at what tubal damage actually means. The tubes are passageways for the egg and sperm to transit and to meet, and for the embryo to end up traveling back to the womb. But it doesn't necessarily mean that a tube that is open is functional. Chlamydia, for example, can damage the lining of the tube, the fallopian tube, but the tube can still remain open. And you do that test and say, oh, well, my tubes are open, my husband is fine, everything is all right, but we're not getting there. The problem is the fine hair-like structures that move the embryos along the fallopian tubes may have been damaged. And so the movement, the scheduled and programmed movement of the embryo along the fallopian tube is impaired, and therefore the embryo may not arrive in the womb at the time it's supposed to arrive, and may in fact implant, because there's a period of 5 days from fertilization at the end of the fallopian tube to arriving in the womb. If the fallopian tube is impaired and that embryo hasn't moved at the right phase, the right speed to arrive in the womb, it may then implant in the wrong place in the fallopian tube, and an ectopic pregnancy can result.
Wow.
So you can see that having open tubes, fallopian tube, does not necessarily mean they are functional. So we have tested for chlamydia, for example, to see whether that has been an event, and then we can treat for it. If we find that either by way of antibodies or by way of tests that we find that there's been an exposure to chlamydia, we treat both husband and wife for chlamydia. It's a very simple treatment. We don't do prescriptions online, but it's a very simple treatment. Your doctor should be able to know what the treatment for chlamydia is available in Nigeria. It's very easy. Therefore, we need to look at what has happened in terms of other infections as well. Have there been tuberculosis that could have affected the lining of the womb? Those are areas that we need to look at. Do we need to treat before we start treatment, before we start the actual fertility treatment? These are actions that need to be taken based on the investigations that we have done and the results we received. Now, I was just talking about the fallopian tubes, and that, yes, when you do your HSG, which you will hear from your doctor very often, HSG meaning hysterosalpingogram, is an X-ray to test the fallopian tubes to see whether they are open. Is the old-fashioned way of doing it. A new technique called HICOSY, hysterocontrast sonography, is now becoming more a replacement of HSG. Now, both these conditions can tell us two things. Both these tests, they tell us two things. Are the tubes open? Yes, they are open, but they don't necessarily tell us they are functional. That's fine. Is there any abnormality within the cavity of the womb? The abnormality can be a fibroid protruding into the cavity of the womb, which may well be the reason this woman bleeds excessively during her periods for so long. It could be a polyp, a small fleshy growth that protrudes into the cavity of the womb. Anything inside the cavity of the womb, excepting a pregnancy, causes the womb to contract. Therefore, an embryo arriving at a womb that is active and trying to expel either a tiny fibroid or a polyp will not have a chance of implanting, because that womb is trying to expel what is within its cavity that should not be there. So these investigations tell us, do we have any fibroids? Do we have any polyp in there? And then if we did find any of this, then we can deal with them as and when necessary, depending on the size of the fibroid or the polyp, or sometimes with tuberculosis or even infection after a previous pregnancy. You can have scar tissue formation within the cavity of the womb. The doctor will tell you there are bands of adhesions, scar tissues, basically. It could be a reason why a lady's period becomes very scanty. After her pregnancy that was successful, she's had a baby, and everything was fine before, and then now I had a baby, and after that my periods are so scanty, and there's very little blood coming through. It may well be that they had an infection after the delivery, and there has been scar tissue formation within the cavity of the womb. Tuberculosis also does this. It used to be very common in the 50s, 60s, 70s, and so on. We saw it quite a lot in those years, but I'm not sure what the situation is now in the country, given the medical situation. I would bet that tuberculosis may well be on the resurgence, and in the rural area we may well be having a lot more tuberculosis coming through again, affecting the womb. So these are things that we learn from the HSG and the HyCoSy, and once we know these facts, we can then arrange whatever is necessary in order to resolve the issue before actually embarking on treatment. Now, other preparatory tests that we can look at will be on the male side. These are a little more far-fetched. I'm not sure how often this will be done in our locality. They have to do with what we call DNA fragmentation tests. Last week I showed you a picture of an electron microscopy test of a sperm sample of a husband whose sperm failed to fertilize the wife's egg through three consecutive IVF treatment cycles. There are other tests, simpler tests now, which we call DNA. D for David, N for no, A for apple. DNA fragmentation test. If your doctor can order, or your lab can do a DNA fragmentation test, it tells us if the DNA fragmentation test is more than 25%, it indicates to us that there is likely to be a chance of poor fertilization rate. The sperm's ability to fertilize an egg will be reduced. It doesn't mean it is absolutely non-existent. It just means that the chance will be much more reduced than what would have been if that weren't the case. Another test is called the hypoosmotic swelling test. Hypoosmotic swelling test is testing the membrane it's like a covering on the sperm by which it attaches to the egg. This is a very simple test. It can be done in any lab, very, very simple. Hypoosmotic swelling test. Any IVF lab or a lab that tells you they do a test tube baby treatment should be able to do that very basic, simple test. It's just exposing the sperm to a solution that is less concentrated than the environment they are used to. Once that happens, the membrane around their head swells up, and then you can see that they have a membrane. You can see it much more clearly, whereas sperms that are deficient will not have that swell, and so will not have that swelling, and therefore you can tell that they have a poor fertilization rate, to them. On the female side, there are tests we used to do. I don't know that they are very important now. We used to call them the cervical mucus hostility test, which hostility test means in the middle of the cycle, the mucus that the neck of the womb produces is favorable to sperm survival. And it becomes less acidic, it becomes alkaline. The pH or acidity becomes more in the alkaline region. So the sperm survive a lot more. We can do tests. It's very simple again, getting the mucus around the day of ovulation of the lady. Put that little mucus on a slide and expose it to, put it beside a drop of sperm and see whether the sperm swim into the cervical, into that mucus on the slide. It tells you whether or not, that cervical mucus is hostile to the sperm, in which case the sperms are not surviving within it, and therefore they'll die. There are other infectious disease tests that we do. They are not mandatory, but in the UK here they are mandatory. And I think most of the standard fertility practices around the world make them standard tests. Syphilis, which is a sexually transmitted disease, HIV, that's AIDS test, hepatitis B and C. These are all tests that are done. Syphilis, basically because it is easily treatable with a course of antibiotic, you want to eliminate that and make sure that the environment your embryo is going into will be fine. Otherwise, birth could be given to a baby that has deformity, or the baby may die in the womb before it is born. HIV and hepatitis B and C are viral diseases. We generally like to see a very low load of virus in the bloodstream of both the male and the female. Depending on who has it, it doesn't really matter. But the important thing is we do not want a situation where either because we are treating a male with whose wife is free of HIV or hepatitis B and the husband is carrying the virus, you make the woman take a risk of contracting that disease because you are using the sperm from a husband that is infected. The husband has to go for treatment and make sure that the viral load is much less than, the virologist will tell you what the standards are. Generally they take over from there and they treat with antiviral medication, and then they send you back to the fertility specialist once your viral load has come down to the extent that the risk of transmitting that virus is much, much reduced or next to nil. So, having done all of this, there is one thing that I don't think we do in the third world as a whole, but in the developed world, it is a routine: pre-treatment counseling. It's more like a psychological thing. You go and see a counselor who sits with you. After all the doctor has told you, the doctor will tell you loads of stuff. The counselor now helps you to actually dilute them and screen them and then explain to you what the chances of treatment will be, depending on the age, depending on the cause of the problem, and what the processes will be. If you are doing your treatment privately, cost will also be discussed because these are stressful elements of the treatment. Fertility treatment is one of the most stressful treatment you can have because one, you are not sure it's going to happen. One, you're not sure you're going to get eggs. Two, you're not sure whether they're going to be good eggs. Three, you don't know whether the eggs will be fertilized by the sperm. Four, you don't know whether the embryos that will be created will be good embryo. Five, you don't even know whether the lining of the womb will be receptive to the embryo when it comes in. These are all unknowns, and the doctor cannot guarantee any of this. I always say the doctor will go so far as to help you along the way. The rest of the result is independent of him or yourself, just as any other pregnancy. It's beyond us all, it belongs to our Creator. But the important thing is to have been able to eliminate those things that can and may well reduce the chance of pregnancy and having a baby happening. By eliminating those negatives, we increase the chance of us getting to where we want to be. So basically, this is what I wanted us to discuss today. I've taken more than 30 minutes, yes, but I think it's well worth it. It's what happens between your having your first visit to the clinic, being told to go and do your investigations. The results of the investigations have now come. The interpretation of those investigations and the implication of those investigations in terms of where we are likely to be going. And if there's any further requirement for any other test or treatment that may well help us to improve on the success rate of whatever we want to achieve. That's basically what I had set out to do today. I said it was going to be shorter than most of our other sessions, yes, but it's been longer than what I had anticipated. And I hope that I have been a little clear, and that if you have not understood any part of the whole talk, please send us questions. I need you to respond. I need a two-way sort of discussion. When I'm in my clinic, after I've finished talking to the patient, I tell them it's now time for me to take the questions. I have been asking you questions all of this time, all about your period, your history, and all the rest of it. Now it is you now to ask me questions, because that way I know what you understand and what you do not. And then we can go through it again, because the more you understand, the better for both of us going along to treatment. Thank you.
Oh, that. Wow. Well, I've just posted a note to say this is a knowledge bank program. What we're hearing free here on this program. Some people have paid thousands of pounds just to hear what we've heard in the last 40 minutes or thereabout. All we are asking is this. Number one, would you please click the share button under the video so that somebody else can benefit from this program? All it takes is click that share button and off it goes. That's number one. Number two, especially for those who have been part of this program, even if this is your first time, all we're asking is some of the things, most of the things I've heard on this program, I've never heard of them before. I don't even know they exist. But for you out there who are hearing it too, whether you're hearing it for the first time, you've heard it before, what are some of the questions that are coming up on your mind regarding this program that we've been doing, especially even today, this post investigation and pre-treatment preparatory procedure that we're looking at. What are some of the questions you're having? Especially, and I don't mean this in a wrong way, especially for you ladies. What are some of the questions that this has kind of stirred up in you? If you don't want to share it publicly, send the email. We will not mention your name. We will make it a general question so that somebody else can learn from it. But we need to have these questions coming in. It will also help that to know that what he has been doing is not just talking to himself all along. Because this is not like our everyday message that we can relate to. These are technical, medical, deep medical program that we're having. And therefore, there must be some questions. So please, he's here now. I won't be able to answer this question when he's not here, so don't ask me.
I may not be here tomorrow.
So please, ask him the questions now.
There'll be lots of other people anyway.
So please send your questions now, and let's go and share this program. Dad.
Right.
Shall I read one of this? We've had 1, 2, or 3 questions. Shall I read
Just
one
read
of
one
them?
for me. Let's see what it is.
Let's read this one. Shall I read this one?
Yes,
the
fine,
one you
fine.
read earlier.
Yeah.
Okay. Now this is the question from somebody. Said, "Sir, why are some people still having their normal menses despite being pregnant for average of 10 weeks, while part of pregnancy symptoms is to cease menstruation?" So why is that, sir? Somebody is pregnant up to about 10 weeks, but yet they're still menstruating.
Right. I think what menstruation are put in inverted commas because most women believe once they are bleeding, they are menstruating. And there can be quite a number of reasons why, bleeding can occur, outside of, in the normal menstrual cycle. Pregnancy, for example, one needs to look at the neck of the womb. Is it healthy? Then is erosion, which can, therefore, say, following intercourse, lead to bleeding. Is there any polyp in the cervical canal or in the cervix itself, in the canal of the neck of the womb, which can bleed? The pregnancy itself is implantation in a position too close to the canal of the neck of the womb, such that the placenta is forming across or into the canal of the neck of the womb. Because behind the placenta is like a reservoir of blood from the mother, from which the baby takes its oxygen and other nutrients. So if you have this forming very close to a canal that links to the external part of the body, then you can't possibly have bleeding occurring in early pregnancy. So these are the sort of very obvious situations that can happen. Ultrasound will be able to tell you whether the baby, in fact, I think when I first came into this country, nearly 35 years now, 35 years now, I carried out some research work which I published, looking at women who bleed in the first trimester, what we call the first 3 months of pregnancy. Why are they bleeding? They're not supposed to bleed. At that time, ultrasound was still very new stuff. And I looked at over 800 women in this. This was a project for my final examination. And I did it and found that actually most of these women have pregnancies with the placenta, what we call a low-lying placenta. But over time, some of these women, as the womb grows, it carries the placenta upwards. and therefore the bleeding stops. But for some women, the placenta just sits across the canal of the neck of the womb, through which normal menstruation will normally come. So they will obviously have spotting practically through the whole of the first 3 months of pregnancy, and intermittently sometimes throughout pregnancy. And in those sort of women, because the canal of the neck of the womb is closed off by the placenta, they can only deliver by cesarean section. Wow. So these are some of the things, that was very long time ago that we found this very interesting finding, knowing that the placenta can form so close to the canal of the neck of the womb and that it can get carried upwards as pregnancy goes on, but in some people it doesn't happen, and you can continue to see bleeding intermittently through the pregnancy.
Wow, okay. You see, that is a part that we didn't cover when we were doing the program, but the question has now brought that up, so that you can see the importance of asking this question. Somebody said, what are the chances of getting pregnant after myomectomy procedure? That we know what.
Okay, yeah. Myomectomy means removal of fibroids. It depends. Unfortunately, the black race is very prone to fibroid formation, and much more than you have in the white, in the Caucasians. Now, fibroid is a degenerative or sort of abnormal growth of the muscle of the wall of the womb. If it grows on the outside, that is inside the abdomen, on the outer part of the womb, which is exposed to the intestine and all that, it doesn't cause you any problem. It won't even cause you any bleeding. Very rarely pain if it goes through what we call red degeneration, where the fibroid has outgrown its blood supply and is beginning to die and shrink. The fibroid can also stay within the muscle of the wall of the womb. In that case, again, depending on the size, it shouldn't cause much of a problem. But if it grows into the cavity of the womb, then it can cause a number of things. One is bleeding, which usually is the first sign. The periods become more prolonged, they become heavier, they sometimes don't clot very easily because there's a lot of blood coming very fast. Now, when the operation for fibroid, usually in our part of the world, is to go on and open the abdomen and remove the fibroid. Now it is possible to go through the neck of the womb into the cavity and remove those ones protruding into the cavity. But when you do this, if you breach the cavity of the womb, then you will create a wound in that special lining of the womb. The lining of the womb is a very special lining, which is more like a carpet that sheds itself and regenerates every month, which is what the menstrual cycle is. Now, if you breach that lining, then it will try to heal, and healing anywhere in the body causes scar tissue formation. And when you have scar tissue formation, you have actually created a problem at that site. Implantation cannot happen at that site where the scar tissue is. Imagine a lady who has had several fibroids removed and multiple breaches of the cavity of the womb. Then you have multiple scar tissue formation. And sometimes, in fact, because of the scar tissue formation, the cavity of the womb can become so reduced in size. So again, these are some of the reasons why pregnancy may not stay or may not happen. But There are procedures now by which we can actually go on and do what we call hysteroscopy and break down the scar tissues and put a coil in the cavity of the womb and leave it there for about 6 months. Put the woman on the oral contraceptive pill for that 6 months period continuously for 3 months, then stop, let her bleed again for 3 months, and then reassess. That way, some women are lucky and you regenerate the lining of the womb. I have a lady who is from East Africa whom I looked after. She was unfortunate. She had a baby when she was much younger, at the age of 19. The baby died because of prolonged labor, had an infection, developed scar tissues in the cavity of the womb, didn't stop having periods, which can happen after fibroids if the scar tissues are a lot.
Wow.
I had to then get her to have a hysteroscopy, release all these scar tissues, put a coil in. Over 6 months, get her to cycle. The first 2-3 months, there was nothing. And by the 3rd month, she started having some bleeding, which showed that we were actually winning. Eventually, we did a treatment. Her ovaries were fine. Her husband was fine. We did a treatment. She has a son now who is about 1 year and 3 months old. She is now looking to undergo a 2nd cycle of treatment at the present moment. It can happen, but it's a question of being able to make the diagnosis. The HSG, which I talked about earlier on, and the HICOSI will help you diagnose this sort of problem. And then the relevant procedures or operation can be arranged. The operation to remove scar tissues in the cavity of the womb it doesn't require opening the abdomen. It requires just going through the neck of the womb into the cavity of the womb with some micro instruments which can then be used to break down the scar tissues. And in a good number of women, they succeed. The same thing can happen in a woman who's had tuberculosis, scar tissue formation, and this can be broken down and then regenerate the lining of the womb again by hormone treatment. So fibroid can create this sort of problem that can scar tissues that prevent implantation and therefore infertility that may not have been there before may then become obvious.
That then leads me to this next question, because it borders on this issue of fibroid and treatment and all of that. This question is, sir, I've had fibroid removal operation, and since then they've been trying to have a baby and they haven't been able to. However, before the fibroid removal operation, this lady had a number of miscarriages. But now that they've removed the fibroid, nothing seems to be happening. What's the...
From that history, you see, I always say medical practice is logic rather than magic. She used to get pregnant, but is miscarrying, and then was later found to have fibroids and had the fibroids removed. So if we follow the sequence, her tubes were fine, her husband was all right, the tubes she was producing eggs, but there was a fibroid or 2 or 3. I've had occasion to have removed 23 fibroids from a woman's womb, a Nigerian woman's womb. 23. This fibroid protruding into the cavity of the womb. Again, you got to be very careful as a surgeon. That's one of the things in a woman in her reproductive age, when you're going in there to remove a fibroid. One of the things you will try your utmost best to do is not to breach or create a hole through the lining of the womb because of this fear of scar tissue. But if the fibroid is a big one, sometimes it's unavoidable. You try and repair what you can during the operation. So pregnancy has been happening, but miscarriages were happening because there wasn't an adequate enough lining of the womb. The fibroid is taking, the place of a pregnancy. And as I said earlier on, anything inside the womb cavity creates a situation where the womb itself is active, contracting, trying to expel that product, which is why women who have fibroid protruding into the cavity of the womb have very severe menstrual periods, very severe menstrual pains and heavy bleeding. So this fibroid is now removed and the woman is not getting pregnant. So we know that there was some space for pregnancy to occur, but the fibroids in the womb cavity prevent the pregnancy from progressing, so it miscarries. Now the fibroid is taken out, a scar tissue is formed. So there's no implantation. Embryos are still being created, sperms are fine, eggs are fine, and tubes are hopefully still fine, because following a fibroid operation, you can have scar tissue formation within the pelvis, and that in itself can disrupt the mechanism of egg transfer from the ovary to the fallopian tube, and therefore prevent pregnancy. So, two things: either scar tissues around the fallopian tube, preventing it from reaching the eggs, or scar tissue in the cavity of the womb, preventing implantation from happening. An adequate investigation would be a laparoscopy to look at the cavity, to look at the womb from inside the tummy, the abdomen, and if everything is fine there, a hysteroscopy, that is a little telescope, pass through the neck of the womb into the cavity of the womb, and then to diagnose whether there are scar tissues. And through that same procedure, those scar tissues can be broken down, and the treatment I outlined earlier on can be followed through. A coil, contraceptive pill for several months, and then subsequently, when periods are properly reestablished, blood flow is much better, then they can try for a pregnancy again. And you can actually follow the development, the improving thickness of the lining of the womb by ultrasound as you do this treatment, which will show you that you are actually winning. All right?
Sir, one question. What is the normal anti-Mullerian hormone, AMH, for a lady aged 47 years for her to get pregnant?
47 years, AMH, based on what I would say I know, would be somewhere in the region of about, it will be less than 5. Less than 5. And we generally say that AMH should be anywhere between, with moderate fertility, we usually say 15 to 25. And 25 to 35 and over will usually be what we regard as normal fertility. So at 47, AMH will be much lower than what we regard as normal fertility. I would say from my experience here, I would say at 47, AMH will be less than 5. Again, at 47, AMH becomes also not only the major issue, it's a question of the quality of the eggs themselves at that age in terms of whether they are genetically normal or not. So, yeah.
Okay. Now, sir, this one is a long question. I'll try and summarize it. Basically, this lady lives in a different place to her husband. She travels to where the husband is. They were trying for a baby. She got back to her station. She saw her period for about 2 months, and then the period stopped. Even though the period has stopped, but the pregnancy test is showing negative. So it's showing that she's not pregnant, but at the same time, she's not having her period.
My first question to the lady...
So the question is, what can be the cause of this irregular period, or what can I do?
My first question to the lady would be, how old are you?
Okay.
If you are 44 and above, then I will be looking at saying, look, this may be what we call a perimenopausal situation. Again, if I go back to not last week, the week before, we looked at the pattern as a woman goes through menopause.
Yeah.
The way it starts is not just an abrupt end to the whole issue. The ovary starts to now apportion eggs. It's like I said in that talk. I said it's like a bank manager telling you when previously you have lots of money and you could draw on it every month, and then suddenly your bank manager sees your what is left is small and says, look, you can't come every month anymore. You should come in every other month. Then when it gets a lot lower, it says, oh, look, you can't come in every other month now. You come in every 3 months. You know, it's the same. That's an analogy. The same way the ovary works. Initially, when menopause is coming, periods are skipped. It may be that the periods come in 1, 2, 3, 4, 5, 6 months. Then suddenly for 2 months, nothing happens. You know, and then it comes on again, and then it begins to get more irregular in that pattern until it stops finally. My suggestion will be that she goes on and do an AMH test. That will give us an idea where she is, and also if we know her age, then we can tally that with the age and then begin to look at what the problem could possibly be.
Okay. One more before we close.
No problem.
There's this one here, which is somebody's asking that if a lady has been on regular contraceptive and now she's stopped, or how does, I think the question is, how does contraceptive affect fertility in a lady? Maybe after a while, maybe she has stopped, or is there a residue that contraceptive will leave behind?
Some women will have a period of what we call post-pill amenorrhea, a period of a few months when the period doesn't come, and then their body now suddenly kicks in again and starts doing what it should do. It does not in any way interfere with your ovarian reserve. It doesn't. The pills do not interfere with your ovarian reserve. In fact, we used to think in the past also that it helps to preserve the reserve, but we now know that that is not the case. The body will continue to still do what it is doing while you are still on the pill. The number of eggs will continue to diminish as the years go by. So the pill by itself does not impair fertility unless, for example, a woman goes on fertility, her weight was 50 kilograms when she went on the pill. And then by the time she stops 6 years later, she's 75 kilograms. Again, you have changed the equation. You've changed the situation. Mm-hmm. Weight has come into the element. That will actually interfere with periods coming through. Mm. So there are so many things that need to be known, but basically the pill on its own does not stop you from being fertile. You know, your ovaries still have the eggs they are supposed to have at the time that you are stopping the pill. Unless, for example, you come in from a family that has what we call premature menopause, and then their AMH level will be low at an early age. You continue with the pill for 3, 4, 5, 6 years, not knowing, you think, I'm still having periods, I'm fine because of the pill. But in the meantime, your AMH level has dropped to below the level that will produce eggs and therefore periods spontaneously. So you could then have, no periods at all, and then you can go on and do your AMH and find it is low. It is not the pill that has caused it? No, it hasn't. It is your genetics rather than the pill.
Okay. One more, sir. This is something that somebody spoke to me about. It's not here. And the lady, she's married, but the husband lives in a different place to where she lives. Now, the question she was asking is, she would like to have another child, but she would prefer to do IVF. Is that possible?
Yeah, it is possible. Now, it's a question of what they agree to do, husband and wife.
Okay.
They live in different places. You know, we defined what infertility means the last time, I think, was this last time, or even
The first two programs.
First two programs.
Yes,
we
sir.
defined what it is and all that stuff and so on. And that there need to be, you know, intercourse at so frequent numbers per week, unprotected per week. Now, if the husband lives in a different place, then the chances of pregnancy will be very little because you meet maybe 2 months in a year. You know, it may just be the wrong days that you have intercourse, and it just doesn't happen. Now, you want to still have a baby as husband and wife. What needs to happen, and I have dealt with situations here, you know, where men in Nigeria, their wives are either working here or they've come here. The man is, you know, has some important business, he can't travel. Then he comes in here, submit a semen sample, and we freeze it. And you know, usually we always say 2 or 3 samples will be better. So we have an adequate backup of sperms, you know, and then he can go traveling if he likes to the moon, and you know, and as long as they both agreed that this sample is for her and for her use only, signed, then she can become pregnant. She can be treated with those sperms. That's a semen sample. There's no problem with that at all. Otherwise, it's a question of what they agreed to. If there was a problem with the husband, then that goes beyond, you know, husband and wife, you know, talking about sperm donation and all that stuff and so on, which is totally an individual problem and decision making. Yeah. But basically, what should happen is the husband should travel, submit a semen sample, sign an agreement that yes, this is the situation, I can't be here all of the time, you know, and that's it, and that should do.
Okay. Well, I think that's all the question we have time to take. Wow.
Go on now.
This is a journey. I never knew we're going to have this type of a blessing. When at the beginning of this platform, I said we are embarking on a journey of discovery, and as you can see, this has been a journey on its own within a journey. What we have been opportune and privileged to hear in the 4 weeks that Dad has been with us, I don't know if we had to pay for it, we will have to be the governor of Bank of England. Because these are things that a lot of people out there will give their right arm just to get the information. Not the treatment, just the information. And here we are, we're having it free. God has been good to us on this platform. And to Him alone be all the glory. Thank you, Lord. We thank you, God, for this blessing that you have brought into our midst, that you have allowed us to partake of this grace upon your Son. We thank you, Lord, because we know this is not by accident. This is a divine appointment, and that is why we are partakers of this grace. To you alone be all the glory. We ask your blessing to rest upon your Son and his household, and you continue to enlarge and prosper them in every aspect, in every area of their lives. Lord, your word has gone forth. Let it find root. Let it find a fertile soil in the hearts of your people. And if there's anybody still out there, still in the dark, not knowing what to do or how to do, grant them the courage to pick up their paper or their phone and send the question so that they may have an answer that will give them victory that they're looking for. Father, we thank you for this program. To you alone be all the glory. In Jesus' wonderful name we have prayed. Amen. Well, ladies and gentlemen, that is all the time will permit us today. In fact, we've gone over our time slightly, but it has been worth every minute of it. Please, even though the program is ending, we're going off air now. If you still have questions, if you still have queries, send it to that email address. And when that will be with us again next week, we will be able to answer the questions. So until next week, when we meet again for another episode, this is Tunde Disu and Dr. Daniel Imoideme saying to you, God bless you. Good night.
Have a blessed week, and we'll see you again next week.
Thank you.
Thank you.